All right, let's get this party started. Hey, thanks everybody for joining us today. We have actually, I'm very excited about this webinar. We usually do educational series, but once in a while we get some new regulations that we can sink our teeth into. And we actually got new regulations November 1st. And for the first time in a long time, I have been excited about what's come down the pike. So let's get a little housekeeping done first. This is being recorded, and I did verify that the recording has been started this month. And if you would, even though we share a YouTube with you, it's for our ACO use only. We wouldn't want that published publicly. So we do appreciate that you keep it in-house. The information provided is only intended to be a general summary. We have not been able to do a deep dive into these regulations yet. We do have some questions about some of the regulations, and I'll point out where our questions are. And as soon as we get clarification, we will be sharing that with you, but there's some really good stuff coming. The ACO Educational Series PowerPoint is in PDF format and is in the handout section. You can download it now to your computer to keep it handy if you have any questions about anything or want to make notes about what's going on. So with that being said, let's hit it. All right. So November 1st, 2018, the regulations for the Medicare physician fee schedule came out. And these will be effective January 1st, 2019. Now, there's some quality, ACO quality topics that we will discuss. The quality measures for 18 remain the same. 19, there's some changes, but the 18 remain the same. So your hunting and gathering that you're doing with your quality measures now, keep it up, keep up the good work. It's the exact same measures that we've been talking about all year, but they're going to change in 2019. So CMS will continue the current coding and payment structure for E&M and office visits. This is significant for the ruling, and let me talk about that. There's been a lot of hubbub that you're only going to have. We're going to 3 billing codes. There's going to be less restrictions on keeping notes in the EMRs to lessen the burden. That is coming, but the payment structure and the coding is the same for 2019 and 2020. The regulations of the notes you have to keep in your EMR are lessening. And this is outside the ACO, guys. Let me preface that. What we try to do in the ACO, we train on ACO measures, but we know who makes up the ACO. It's our physician partners. It's our post-acute partners. Our partners make up the ACO. We're merely the administrator for this ACO model. So we'll try to bring out things that will be important to you as a physician's office in this webinar also, not just what's valid for the ACO. Because, you know, it's kind of one of those things, what's good for the goose is good for the gander. Because what is good for the physician's office is also good for the ACO. So for 2019 and beyond, CMS is finalizing the elimination of the requirement to document the medical necessity of a home visit in lieu of an office visit. That's big. We have a lot of providers that do home services. This is significant to you. So this is going to be one of the pieces of the rule that will affect a lot of our providers. So it's the elimination of the requirement to document the medical necessity of a home visit in lieu of an office visit. So we'll do a deep dive into that as we go along. This is our high-level webinar, just to make sure you understand the regulations are coming down the pike, and we will dig deeper into these if you need help with them. Modernizing Medicare physicians' payment by recognizing communication technology-based services. Wow, this is awesome. What this means is CMS is stepping into the 21st century. They are going to allow and they're going to pay for. That's the significance, isn't it? You could always contact your physician on the phone, visual check-in, some kind of recording or video. You could do that, but you weren't paid for it. Now you're going to get paid for it. Calling is a part of that program. So you can check in with the physician, and the physician's going to pay for it, even over a phone call. We have the chronic care management, but this makes it a little bit deeper and a little bit more robust, because at the physician's office level, a lot of these things can be captured. Practitioners could be separately paid for the brief communication, technology-based service when the patient checks in with the practitioner via telephone or other communications device to decide whether an office visit or other service is needed. This would increase the efficiency for practitioners and convenience for beneficiaries. So what are we saying here? These codes that Medicare is paying for are hoping, because you're going to receive reimbursement for them, it will lessen the burden of the actual patient flow through the clinic. Let's think about this in broader spectrum. Primary care, there's a shortage, period. I think everybody knows that and has bought into that. A lot of our primary cares are retiring. We're getting a lot of nurse practitioners into the population of practices that will become very significant, and in this regulation will be have some advantages that they didn't have before. But we're trying to lessen the load on the physicians. There's some new chronic care remote monitoring codes, and we're going to call those RPMs. These new codes are for patients not seen by the practitioner within 1 year prior to billing. The practitioner must have a face-to-face visit with the patient before they do this remote monitoring. So let me repeat that. I'm going to ask a question here. So patients that have not been seen within the past year need a face-to-face visit in order to do the remote patient monitoring or an annual wellness visit or an E&M code. What does this sound like? I want you to put under the questions, type in what this sounds like to you, what this rule sounds or mirrors. The first one that does respond correctly to that, I'll give it a minute here. And Kara, I'm sorry, you don't count on this. You can't answer this question. What does this sound like? A face-to-face visit with the patient must be done before you can do remote patient monitoring if you have not seen the patient within the last year. Well, yep, it sure does. And we have, bravo, Lisa, you're going to get the award today. And actually, it's going to be a little gift card to Dunkin' Donuts, so you can get a coffee. Yeah, there you go. Anyway, that's exactly what it sounds like. It sounds like the chronic care management rules. So here we have remote patient monitoring and the non-face-to-face technology. It's similar, isn't it? The remote patient monitoring is going to be similar to the chronic care management and can be an add-on to the chronic care management. Pieces of it. You can use a telephone, Holter monitor, Fitbits, artificial intelligence messaging, you know what that is, text messaging and things like that. Secure, of course. We have some of these platforms available for you within our ACO network and model. So we're going to be rolling some of these things out to you also. But these codes, again, are billable. So here's the different codes for the remote. We have the 99453, 54, and 57. Each of these is a little bit different. And on one of the codes, the 57, the last one, there is some controversy over it. And we'll go over what that controversy is. It's a little frustrating, but we do already have questions out to Medicare to ask for clarification. As it turns out, we're not the only ones. Apparently, there's a lot of hubbub on the internet about, number one, about these codes, and number two, questioning how you can implement that. So the first two codes, we believe that the chronic care managers can do this, or the physician's office can do it also. So the first is the remote monitoring. In other words, weight, blood pressure, pulse ox, respiratory flow, and this is the initial setup and patient education on use of equipment. Do you realize that except for the weight piece, all of these can be done on a smartphone now? That is wild. You can do EKGs with a little add-on device on a smartphone even. Cray cray, the new world we're living in, right? So this is the setup. There's an initial setup, and that's the first code. The second code, the 5.4, remote patient monitoring, and this is for the collecting and the transmission of the actual record, and this can only be done once every 30 days. So we must be able to get the information from their device to us or to the practitioner, and that's a code that's paid once every 30 days. The third code is where the question comes up as far as supervision, and we'll go over that. This is a 20-minute code. It says clinical staff, physician, or other qualified health professional within the calendar month interacting with the patient or caregiver, so it could be the daughter, the wife, the husband, etc., during the month for the patient on the remote monitoring. Now, again, we'll go into the type of technology that qualifies. We listed some of them, right? The smartphones, the Holter monitors, but Medicare hasn't quantified what they are going to be specifically. So they didn't tell us exactly you can use this one, you can't use this one. So we're going to have to, until further clarification comes out, if it does not come out by January 1st, we're going to have to use just good sense into what makes sense into your program, right, for this type of technology. Medicare will give us additional guidance, just like the chronic care management. We started it in 2016. It has developed to a whole new program in 2018, and we've had additional guidance. The biggest additional guidance, I think, is for the chronic care management, is they came out and had the medical decision-making process wired into the chronic care management, which I think is actually a very good thing. Are you serious? So that last code, the 99457, the question is, what level of supervision is required? CMS has said that the 99457 describes professional time and therefore cannot be furnished by auxiliary personnel incident to a practitioner's professional services. So my interpretation of that is it must be under some form of direct supervision with the physician. Now the question is, though, I like this little meme here, which way do you want me to go, right? The services, the way that the law is written, the 99497 services are to be performed by the physician, qualified health professional, or clinical staff. This is exactly how it's written in the Federal Register. The clinical staff, now this part is not, but the clinical staff can include RNs, medical assistants, subject to the state law scope of practice. So the interpretation here would be that the clinical staff could perform this. It doesn't have to be the physician. That's what this infers, under their scope of practice. So if a nurse can do this under their scope of practice, or an MA can do this, a medical assistant can do this under their scope of practice, then it should be allowed. The inclusion of clinical staff is the most significant difference between a code that's already been established that is similar. That only limits physician and qualified healthcare professionals. All the practitioners must practice in accordance with state laws. So it's the state law and clinical staffing issue that raises the question. The reason why this is such a problem is because there is a conflict in understanding the actual supervision requirements. This is an incident 2, but is it a general supervision or is it a direct supervision? CCM, chronic care management, is a general supervision. In other words, you can do it outside of the physician's office. Anybody can do it as long as it's under their scope of practice. It infers that this is the same way, but it is not written that way in the law. So we have a spirit of the law and we have a letter of the law. My suggestion is, until clarification is given, you follow the letter of the law. That's what we will educate on, is the letter of the law, until we receive additional guidance. So as we roll these different types of codes out, we will, for value-based medicine, because these are all value-based medicine codes, and we will be helping you with that, educating on them, how to implement them and what the rules mean and what they say. This will be all part of our value-based medicine practices. So we'll be educating out on each of the component pieces for each of our groups. Now here's something that, quite frankly, we have been petitioning and petitioning and petitioning Medicare for over and over again for the past few years. Finally, Medicare is going to allow voluntary alignment to nurse practitioners in the ACO. So what this means is, a voluntary alignment means our nurse practitioners are different types of mid-levels that have their own clinics. Yeah, they have to be supervised by a physician or have a proctor. Different places call them different things. But their attribution has been very low because it had to have a physician as a driver, an MD, a DO. Now, through voluntary assignment, we can have the patient population assigned to them. This is tremendously significant because when it's time for them to get a piece of the shared savings pie, it's based on head count. So if your facility only has a head count of 1, your pie isn't very big, is it? So voluntary assignment, let's get into what voluntary assignment is. The first thing that voluntary assignment is the Medicare recipient actually has to go on mymedicare.gov. All right, my poor father, I hope he can't hear me today. My dad's not going to do this. My dad's not going to be able to do this, but his care coordinator can walk him through it and do it with him. Now, there you go. So we have care coordinators within our rural health clinics. We have care coordinators within our FQHCs. We have care coordinators in our mid-level offices. Now we're going to get a head count to make it count for the ACO also. So we have a step-by-step process. Again, we will guide you through this. We will train the care coordinators on this in the offices if you're not using our care coordinators on how to enroll in this. In addition, we're talking about the apps, right? We have an app out there that we can use, and it's free for the patient to log in and get their medical information on their phone. This is part of the enrollment process. So they can actually access the information themselves. And there's a little video on how to do it. Again, this is free. All this is free. Medicare is putting this together for us. And as an ACO model, what we are doing, we are administrating it for our population. So this is huge. Number one, we can get the attributions for our clinicians now, for our mid-levels. They have been left out so many times. They already receive income of less than the physician. But this will up their game. Through MACRA, through the ACO, their reimbursement in value-based medicine, I can't leave that out, will suddenly become higher so that they are reimbursed closer to what the MDs and DOs are making. It is tremendously significant. So here's our little YouTube on the how to get the app and how to get the download for the registration for Medicare. Again, the care coordinators need to be familiar with this, because we're thinking that the care coordinators will really kick this off for the patient population. Now here's something kind of fun. They're removing 8 quality measures for 2019. I told you there's some quality measures for the ACO that's changing. 2018 is the same, exactly the same. 2019, the measures are changing, okay? So what happens? They're taking away 8 of the core quality measures. So we have an outline of what the quality measures are. The quality measures that are being removed are some of the hospitalization admin. In addition, we only have to report out on 10 quality measures. So they've taken a number of them out of the ones we even have to report out on. So that's huge. That'll make the burden of reporting much easier on the facilities. We will start the build out for 2019 after 2018, because most of the EMRs is just going to be a matter of removing it, clicking a box and taking it out, unchecking something. So, but we will help you with that. Oops. One of the things that they have kept is which I was a little missed about, was the screening for depression remission that is still in there. And the reason why I was a little sorry to see that one stay is not because we don't have behavioral health issues in the United States, but because this particular measure is very difficult for physicians' offices to gather. So this is probably one of the more difficult measures that has remained. Okay, so also part of the 2019 rule, if your contract period was ending with the ACO in 2018, which all of our ACOs on this particular call are not ending, but if you have friends and family that are in other ACOs, and some of the people on here do have some associates that 2018 is their last year, they have a 6-month extension. And if any of those groups need help with that 6-month extension, would be happy to help them with that. Updated the definition of primary services. Ooh, I love this one too. This is significant because, let's think this through. The more patients you have in your population, the easier it is to understand your cost, because patients aren't coming and going and coming and going, right? So you understand your cost better. If we have the patients where they can self-align with the different types of practitioners, mid-levels, specialists, whoever it is, they can self-align. One way to keep up their attribution and increase their attribution are through various codes. Every single one of these codes are considered a value-based medicine code. We have the advanced care planning. We have the administrative health risk. We have the codes for annual depression screen, alcohol misuse, and alcohol screening. So all of these codes are codes now that will solidify attribution, in addition to our chronic care management codes that we're doing already. So this is significant to hold your population steady or increase your population. What that means is, remember, this all translates to revenue for the physician's office or for the ACO also. Rural health clinics and FQHCs have been left out for so long on so many different measures. Finally, CMS is coming around and saying that the RHCs and FQHCs have these different types of codes, and these are the remote codes also, but they're in a G format. So we'll educate on this too. And these are the global rates. So they're actually paying a fee-for-service rate for a rural health clinic and FQHC. For those of you who do not know, rural health clinics and FQHCs are paid on usually only face-to-face visits, and they get one lump sum. It doesn't matter if they spend 5 minutes or 5 hours with a patient. They're paid exactly the same. It's called an AIR rate, all-inclusive rate. Now, through rural health clinics can bill chronic care management, and they could for 2018. They get a one particular code, but it pays fairly well too. It's a blended of 3 different codes. And now they have decided that the communication technology-based services for the remote evaluations, the same thing that the fee-for-service have, are going to be paid too. That is significant. That is really significant, especially for FQHCs and RHCs. What they're doing is they're trying to level the playing field and allow our rural participators and the people that really do serve the underserved population or the population that has very difficult access to care. And every one of our ACOs has rural health clinics and FQHCs in them. We serve a rural population, a large rural population in many of our locations. So this is very significant. We will be working with the RHCs and FQHCs on these virtual communication services. One quickie here for the RHC and FQHC. This G0071 is one of the new virtual communication services, and the requirement is only 5 minutes. It's a remote evaluation service that I picked this one to talk about today because this one will allow us to evaluate whether the patient needs to come in for a visit or not. And so the medical discussion or remote evaluation is for a condition not related to a rural health clinic or FQHC service that was provided in the previous 7 days. So 7 days before, was it discussed? So it has to be a new service, right? The medical discussion or remote evaluation does not lead to a visit within the next 24 hours. So that's pretty, so what they're trying to do is reimburse the physician for taking care of the patient over the phone, and it can be over the phone on this. So, but it's only a 5-minute communication. That's huge. It's technology-based. It doesn't have to be phone. It could be other means too. So payment for the G0071 and these other services are all paid on the fee schedule, but you will still bill them the same. You'll still bill them under the Part A, just like you would your normal face-to-face visits. But the piece of this that I was really excited about was it was specifically addressed in the Federal Register that MAs or Medicare Advantage plans, so Medicare Advantage plans or Medicare HMOs must include these rates or these codes and pay for them. It was specifically outlined and stated in the Federal Register, even for the rural health clinics and FQHCs. That is quite significant. So we were really excited. I was really excited to see that the Medicare is really going to be putting down their foot on these codes and making sure that the MA plans do pay for them. The Medicare Advantage plans do pay for them. I think this opens up a huge avenue for all of our practitioners, all of our care coordinators, all of our physician offices to up their revenue in the MA world, in the HMO world. Bring on all payer sources, treat all patients as the same, even in these types of plans, the Medicare Advantage plan. When we're doing that, we're going to start going to the different Medicare Advantage programs and saying, look, our patients are participating in value-based medicine. We want you to pay us like an ACO. Give us a bonus for doing this extra work because we're keeping your patients healthier. So we're going to start working on some of those contracting issues. All right, that's what we have for now. And what we're going to start training, and we're going to, y'all will have to decide who's going to need to lead, is your ACO lead, who's going to lead the regulatory charge, the implementation charge. If you want to do these new types of codes that are available come January 1st, I see them as a tremendous advantage and a nice transition into the virtual world of medicine. I think it's a nice soft step for practitioners and for patients alike. My dad, who is not tech savvy, but is a great guy, can pick up a phone and call somebody and talk to the doc, or talk to the nurse, or talk to the care coordinator. He's not going to be able to do his, blood pressure on his phone maybe, but he can call. Well, that communication can be paid for now. So suddenly this revenue is pumping back into our primary world. We're trying to keep our primary docs alive. This is the lifeboat that we've been talking about. This is value-based medicine. This is how we're going to keep them alive. This is so significant in the change of healthcare today that we must take hold of this and push it forward for the survival of our partners, for the survival of who we are, for this just the connectivity alone is huge. All right, well, I was on that soapbox, wasn't I? Let's see here. We see if we have some questions here. Let's see. Okay, I may be premature, but since the doctors are able to remote, what incentive it to remain in CCM? Okay, that's a good question. So one of our care coordinators is worried about their job, it sounds like. If the doctors are going to be able to do remote, why stay in CCM? You can't get rid of CCM because CCM dovetails with the remote. The remote, the care coordinators can do also. There's too much of a burden in the overhead of the offices already. They're overworked and understaffed. And this particular person should be very sensitive to that, because some of your physicians, as it is in the different types of homes that you work in, they're all understaffed. So this is huge. This is huge for care coordination, for value-based medicine as a whole. It does not exclude the care coordinator, because some of our offices aren't doing care coordination, and we're trying to get them to. Care coordination is the cornerstone. If you do not have care coordination, you will not be able to succeed in value-based medicine. You will not be able to succeed in the ACO because you will not save dollars. You are missing the boat on value-based medicine if you're not doing care coordination, because care coordination is the cornerstone. I hope that answers your question. Can the LPN do this as well? Yes. But remember that one code, that 57 code, we need additional information on. Okay, so we're seeking guidance from Medicare. For right now, that particular code, I'm going to say no. It needs to be done in the physician office. But we'll find out. It is very counterintuitive that they would have written it like it is. I think, quite frankly, somebody made an error in the wording. That's more or less, I think, from some of the other attorneys and things like that we've talked to, healthcare attorneys. They think that there was probably some kind of error made, and there will be a clarification shortly. Can the care manager claim CCM time for helping patients sign up on the Medicare.gov portal account? Ooh, good question. Let me cogitate on that one. I'm going to say, I sure would like to. Let me cogitate on that, and I'll get back to you. I will send out, when we send out the video on this, and when we send out the slide deck, we'll address that issue and the other questions that are coming in here. Let's see. We're running a little bit over time here. So if you do have any questions, hopefully everybody knows how to get in touch with us now. I put my phone number for texting. Honestly, that is the best way to get a hold of me. We are out in the field and we're educating and we're traveling and we're working hard to come up to speed for year end and get ready for 2019. But I've always got my silly cell phone with me. If you text me, I will respond. If I can't respond that minute because I'm in an airplane, as soon as I touch down, I'll make sure that you got, we have some kind of touch. Melissa, the #1 executive assistant here, I made the slide deck, so I got to put that on there. I'm sure she's going to be happy about that. She's available also. That's her cell number. She has her cell phone with her 24/7. But I'm going to ask, let the poor girl have some downtime. If it's after business hours, maybe, text her the next morning or text me. I don't mind receiving text at night, but she's got a kid. Let her have some downtime. But that is her text number also. And I think that looks like all the questions for now. Well, thank you everybody for joining. I know this is very high level, and one of our providers said, when we had sent this out initially, boy, this is clear as mud. Hopefully we've cleared up the mud just a little bit. We will be doing deeper dives for everyone. We'll be setting up educational strictly for these codes and for the different types of processes to onboard, especially if you have a lot of mid-level clinics or a mid-level, you're a mid-level practitioner. I just hate that word mid-level, but we'll work with that to try to make sure that we get we get some bang for the buck there. All right, everybody, thanks again. I hope you all have a great day. May the force be with you.